Well, our next speaker, we've talked about a lot already, and you've met him on the panel. So why don't we just bring him up, Dr. Thomas Odorizio.
Thank you very much. It's a pleasure to be with your group today. I want to thank the Wegemans and Dr. Jean for helping to put this together. A lot of comments on my tie. I have to tell you what happened. This is I'm a tie horse, as many of you may know or may not know. So this is tie number 270. And I got it, no, it's a personal story. I got it at the Detroit airport in that little shop, Pangborn. It's called Pangborn Ties. They use local art to put them together. And somehow when I got it, I said, this is going to be a special tie. I said, I don't know why, it's going to be a special tie. So I wore it a few times. I kind of wear it certain days and what have you. I'm pretty bad about this business. And so about a week ago, and you know, I always like to try to spiff up for the folks I see in the hospitals. So about a week ago, I happened to be on the wards and attending with a large group of residents and 2 other attendings. And we went in to see this person, and he was lying in bed, and they were talking to him, and he stopped. And he looked at me. I had this tie on. And he said, "You look like a real doctor." This is a true story. And I said, I went up, I have to tell you, I'm a needy, a lot of you know I'm very needy, so I went up to him, I shook his hand, I said, "Thank you very much." And he talked a little bit more, and then we walked out of the room, and I said, "What's this gentleman in for?" And the doctor said, "Delirium." That's a good so that's it. I'm telling you, it keeps you very humble. It really does. So today what we're going to do is we're going to kind of reinvent a few things that Arthur brought up and Jean brought up. I'm not going to touch the territory of Dr. Go. You haven't had a chance, many of you in the room yet, to hear his talk on nutrition. It's clearly probably the best talk I've heard in over 15 years on nutrition. Dr. Go is a national and international expert on nutrition, so I won't tread that ground very much. But I will talk a little bit about some of the work you've already seen, some of the slides from Arthur, because I do believe in the Latin that repetitio est mater studendum. So repetition is the mother of learning. And I'm going to just share a historical slide or two. This is the man who identified the cell that we all know as the neuroendocrine cell. And I've changed this a little. This was a special gift from a late pediatric pathologist that he had in his collection. And this is a neuroendocrine cell. And people who know a little anatomy will notice that that looks just like the cell body, and except for the tips that don't have the little dendrites on it, that could look like a nerve body cell. So, but the thing that makes this cell unique and the tumors associated with it, as you all know, are the granules that they secrete, the hormones that we saw were packaged, as Arthur pointed up, and the clear area around it. He used the German word Helizellen, which means clear cell, and that's because Ferter saw that clear area around the nucleus. And I put the receptors on it, which we heard from Paris as being locks, and the keys fit into the lock. And the principle for radioimmunoassay is, and the peptides that we measure is identical to the principle that we use for peptide radioreceptor, and some say nuclide therapy, but we know it as PRRT, which is now in the United States, as we've also heard. But these cells possess, by their nature, they possess the locks. And when the key fits into the lock, in the case of this receptor, this lock, it's somatostatin and or its congeners, which are sandostatin or octreotide, or lanreotide or somatulin. They're the same drug. So the 2 types that we talked about and you're aware of are the keys that fit into these cells. And when they fit into the cell, it does two things. As we heard, it shuts off the release, or it slows the release of the hormone that you're making too much of, and it also keeps the cells from proliferating. So it's an anti-proliferative. We've known that in vitro, and then the work that was described about, by Rudy Arnold from Germany, the PROMID study, now shows that it does have therapy, not just symptomatic, but therapeutic benefits. And this is the cartoon of the same cell, and these are the tumors that we know that we have in the United States. The approximate incidence is about 114,000 new cases per year, and 13,000 new cases per year, and the prevalence, how many on any given day in the United States are there? There's probably about 125,000 cases. Now, Dr. Sue is going to release a publication soon that talks about the neuroendocrine tumors, and she goes to the age of 30. She considers adolescence all the way up to 30. I told her to stretch it another 2 or 3 years, decades, and we'd be, we'd all be in the same numbers. But but in the children, it's about half of that in terms of incidence. Neuroblastoma clearly being heretofore the most common but virulent of the pediatric neuroendocrine tumors. We now know that children suffer, mostly in the teenage years and early adolescence, carcinoids and pancreatic neuroendocrine tumors, just like adults do as well. But on there you can see all of them, including carcinoid, pheochromocytoma, which Arthur and I have special interest in, maybe, hopefully not, but that may have malignant or metastatic pheochromocytoma, which, although technically you have to be careful in terms of the cell type, is nonetheless considered neuroendocrine in nature. And this is Oberndorfer, who coined the term carcinoida, which was an unfortunate term, but he described as a pathologist what he saw. He looked into the scope and he saw this tumor that did not look necessarily like a bad cancer. It looked almost normal. In that regard, then, he said, but it's moving around in the intestine. It's gone through the wall, and therefore it is cancer-like. And so the German word carcinoida means cancer-like. He coined the term in 1907, and they celebrated his 100th year of the coining of the term in Paris, France, a few years ago. This is the slide that Arthur has put together that I use, and I put a little bit more on it as the far right that Arthur showed this morning, but that 25% is the pulmonary foregut tumors that he talked about, lung carcinoids. So they make up about 25%, and the intestine makes up about 55% or 56%, as you saw. And those numbers in different studies hold up in terms of the distribution of carcinoid tumors. This, again, was not really Oberndorfer. He coined the word, but the Luberasch was the first to describe the tumor itself. And again, that's the approximate prevalence and incidence, as I mentioned. Now, the nature of neuroendocrine tumors are very important. We lose sight of that when we think about carcinoid tumors. But when you do neuroendocrine tumors of the pancreas, you recognize the interest, you recognize something very important. If the tumor is making something like insulin, it doesn't make insulin all the time inappropriately, it makes it episodically. That is to say that things will be fine, and then all of a sudden the inappropriate rise of insulin in the setting of a low sugar precipitates low sugar response, the hypoglycemia. The same for gastrin secreting tumors of the pancreas. So we know when a peptide is important as a hormone in your body and mind. When it's an important hormone, you make too much of a good thing, you will have symptoms or syndromes that Arthur alluded to. But the carcinoids do the same thing. They make too much of a good thing. And as we know, the carcinoid of the midgut makes a lot of serotonin. It also makes a lot of another hormone called substance P, and they're co-released. But they're not always co-released. And people will have symptoms, as Arthur alluded. I'll show it again. They may have symptoms. They'll go away for years. And then once they sustain their secretion, then the syndromes become prominent. But it is of a high concentration of serotonin in the midgut. And that's what I mean when I say episodic secretion. They're not autonomous. That is, they behave by control mechanisms. And we believe that the controlling mechanism is the somatostatin receptor, the lock, and the key is somatostatin/octreotide/lanreotide. They predilect as well when they're in the midgut area and pancreas to the liver. And there's a reason for that. And I'll show you in a moment. And this is the slide that Arthur put together several years ago, and based on his series of 100 patients, which shows the slow progression, but the episodic kind of nature. Vague abdominal pain, irritable bowel syndrome. Many are diagnosed and misdiagnosed. We've seen now 3 Crohn's disease, regional enteritis is misdiagnosed, and they were really carcinoid tumors. And it's variable, and it has to do with the episodic release of these hormones after they've been lost control by the body's somatostatin. This is my Matisse. I tried to do this for you to make a point. And what you see there is in the ileum in the lower left corner, a tumor. And that red structure going to the liver is called the portal vein system. Arteries carry blood to the tissue for oxygen and what have you. Veins classically carry blood away from tissue. In this case, the vein is taking up seeds of that carcinoid tumor or the pancreas and bringing it in an arterial way to the liver. And that's why almost simultaneously in 70% of the instances when the carcinoid of the midgut's found, that's why it's in the liver. The seeds have already been taken almost instantaneously from the tumor of the ileum to the tumor of the to the pancreas. Gene also alluded to atypical, or Arthur did, with the why the foreguts include ovary, and that's because they don't drain blood in the portal system. Only those tissues, predominantly the small bowel and jejunum, as well as the pancreas, drain blood from the tumors into the liver directly and supply about 55% of the blood supply to the liver. So it's no surprise that many times at the time of surgery it is found by the surgeons to be present in the liver. Now the neuroendocrine tumors again make up 50 to 60%. If you add the 25% from the lung, it gets almost up to about 85%. But there are foreguts, which we heard. The foregut tumors are lung, stomach, duodenum, ovary, thymus, and pancreas. The midgut is jejunum, ileum, colon, and appendix, of which the vast majority are the ileum, to the end of the small bowel. And then the hindgut are considered the rectum. However, the hindgut can also be the transverse colon, and those tend to be very quiet, very soft-spoken, but aggressive. Quiet as in no real syndrome or no real symptomatic problem, and that's because the hindgut doesn't have many serotonin cells that can give us a biologic response. Now the neuroendocrine tumors, Arthur alluded to them twice. The pancreatic neuroendocrine tumors, 40% of all the pancreatic neuroendocrine tumors are functional, and that's a real word with no quotes on it. And then there's a large group that are non-functional, and those have to be in quotes because, as Arthur said, we're not smart enough yet to detect what peptide or hormone that they're making. I interchange peptide with hormone because these hormones, not like estrogen or testosterone or cortisol, these are peptides. These are amino acid proteins stuck together that act like hormones because they're released into the circulation and they do their deed on another tissue. So serotonin works on the skin, works on the intestine to cause secretory kind of diarrhea, hypermotility. It makes the bowel move very quickly when it's in high amounts, and so on and so forth with insulin, excess insulin. Gene alluded to it in a recent paper, but the bottom line is these tumors may have 2 or 3 different hormones in them, but it's what circulates in the blood that gives them their syndrome. So if you make too much insulin and you have low sugar, it's an insulin tumor. If it's too much gastrin and you have ulcers or high acid, it's a gastrin-secreting tumor. And they used the term a few years ago of OMAs, insulinoma, gastrinoma. And that's how these terms come to be. Even though there may be 2 or 3 other peptide hormones in the tumor, it's the one that circulates that wins. Carcinoid tumor biology, we've heard a lot about that. The cell I showed you was stained with neuron-specific enolase. Because of the non-specificity of it, it's not a good staining nor a good measuring hormone in the blood as a marker. But synaptophysin and chromogranin A are very much good markers because they all have the essence of these stains. And that helps to describe the cell itself. It's not just that it has a clear halo around the nucleus, it's because these have stains that have either synaptophysin or chromogranin or both. Gene's work is very exciting in terms of the chromogranin A expression that he's doing and what he showed, because we don't know, we might someday be able to use a ratio or a semi-quantitative number of the staining potential with the chromogranin staining potential and come up with maybe a predictive factor just using those 2 stains. But the cells all are rich with secreting little granules. These are little storehouses, as they were referred to. And as Arthur showed, these tumors can make very exotic hormones that exist normally in our blood. For instance, corticotropin-releasing hormone, which causes ACTH, which causes high cortisol and gives you Cushing's. And in fact, the first tumor was a carcinoid tumor that it was discovered in. We didn't even know we had it in our body until the tumor was found. The same way with growth hormone releasing hormone that causes growth hormone that causes acromegaly. We didn't even know there was a GHRH. They suspected it, but they were found as well in carcinoids. So carcinoid tumors are the lessons of nature in the way they pathologically behave, that we learn even normal hormones in our body from that. This is the WHO classification, World Health Organization. It was alluded to already. There are really 5 types, but the 3 we're most interested in, and that's very important to keep in mind, are the 2 well-differentiated. One's a well-differentiated tumor called the typical carcinoid. The other is the well-differentiated neuroendocrine carcinoma, which is the atypical type of carcinoid pattern. But the 2 are considered the same in terms of prognosis. And Arthur alluded to that, and I'll show you the slide again. But for the most part, the good news is most of the tumor types of the neuroendocrine tumors that you suffer are the type 1 or type 2. The third one is the one alluded to, which is poorly differentiated. It doesn't look like a normal cell. It's a small cell, or it can be a large, and that's morphologically small, versus a large cell with neuroendocrine staining, chromogranin A or synaptophysin, and then the other 2. This is a worky slide. I liked it. It was modified from Solchia's book, the 2000 World Health Organization, where the classification came. But you can see all of the ones in even fetal and paraganglioneuroma, medullary thyroid cancer, pancreatic neuroendocrine tumors. All of them have the stain, synaptophysin and chromogranin A. That gives them their essence of being the cell that we know and work with, and the tumor. Now I ask you, if you would, I'm serious, turn to page 17 of Arthur's piece. It's in the lower left-hand corner. It's 4 slides back because it makes a point. Arthur showed the historical progression of what's being done in neuroendocrine tumors, beginning always with surgery and continuing with surgery. Then he showed chemotherapy, then chemoembolization, then interferon therapy, and now the anti-angiogenics. All I did was scramble that linear lines of Arthur's to show you the algorithm. And this is really the body of what I'm going to be sharing with you in a rather superficial manner, or as good as I can get. And that is that each box represents an option of care. And as we learned and as we've talked, every box is a good option. but a good box at a good option at the wrong time isn't your best option. And that's why you go and you talk to people who manage these things, because they can help you with what they know about you to help you make the next best algorithm, make best decision. If you look at those arrows, they are mind-boggling, but they go back and forth. They're not one-sided only, that you can go back. You can go embolization and then go back through and do liver surgery. So there's nothing fancy about these, or you can do primary surgery, or you can do PRRT. I tend to like to go to the peptide radioreceptive therapy. I've made a solid line of that since. And now over on the left side are the pathology part of our boxes or options, because they give us an enormous amount of information, as does especially the markers, the tumor markers that we're hearing more and more about. In terms of the Ki-67, also called the MIB1, just happens to be a different part of the key. In this case, Ki-67, it's a piece of that they make an antibody to. But since they've been made in perpetuity, they can be done commercially, and every pathology lab does a Ki-67 or an MIB1. And one of the criteria for commerciality for a pathology group is that they have to have an antibody in perpetuity for the world to have before it can be commercially, because it's standardized then with the stain. So the antibody is very specific to the one area of the chromosome that reflects proliferation, activity of the tumor. And so that's the number that you get when they do the stain. It's a stain off a tumor tissue. Its proliferation refers to the percent of cells that are positive in a section. You've seen two pictures of it. We'll show you a third. Now, the well-differentiated carcinoid and the moderately well-differentiated carcinoma, so both of that, usually have a proliferation index of less than 2% or less than 5%. It's that large group that you saw a slide of Arthur's, I'll show it again, where 15% of the cells or more have the high proliferation rate, and those are the more aggressive type 3s. It depends, and it's been cut two different ways, but you need to keep in mind that well-differentiated precedes the two that are lumped together, and usually 2 to 5% or less is the general classification for the tumor or the carcinoma. This is the Ki-67 or the MIB1, and this is obviously a very high increased proliferation. And you can see the nuclear staining. You can see the nuclear staining of the proliferation rate. Now, if it's highly positive, it can assist in planning therapy. A high index may justify more aggressive therapy, such as chemotherapy. The limitations are as alluded to, and James is breaking new ground with some of the findings in each of the different areas. The primary tumor, the nodes. We've learned that the nodes may be very, very important. The liver may not be the accurate reflection. I think there's problems inherent inside of the staining problem, and I'll show you that in a minute, because the Ki-67 can vary from tumor slice to tumor slice, even in the same tumor. So here's my classic salami, and you can see that the salami is made up of little fat globules in solid tissue, and if you cut it there, you get one answer. If you cut it there, you get another answer. So it's very important, because when you think about the cut, it's a 5-micron cut. I mean, this isn't Deli sandwiches. This is pretty thin stuff. And so you can see how one area or another can change, even within the same tumor. It can change a Ki-67 index. As Gene said, there's a certain pathologic way that they cut the blocks, but even within that block cut, there can be differences. So you need to be careful when you come in and say, my Ki-67 is very high, and we have seen less than 5% Ki-67s, and a patient came in with a MET. It was in her breast. and it was a 25%. And there was no difference in the behavior of that tumor. We followed it with just sandostatin. There was no different behavior in it whatsoever to the other tumors in her liver. This is the paper Arthur showed. Our Bifagiano, similar to it, the Journal of Endocrinologic Investigation. And what they did was take 31 patients with NET tumors that were archived, evaluated by 3 different pathologists using the 2000 Solcia NET classification. Excuse me, I'm sorry. Coughed right into the microphone. Pardon me. Sorry. It's tired. You see me shrink right down behind this thing. Either that or walk right on over this edge. That's the other thing I'm prone to do. And there's the classification again. But you can see the 2 well-differentiated carcinoma. Those 2 were lumped together. The poorly differentiated stood clear out as a completely different histologic cell with neuroendocrine properties. And the punchline on this was the Kaplan-Meier curve. And I'm just going to go ahead. But what was shown before is that the well-differentiated tumors, which included the carcinomas, which had Ki-67s of, in this case, they went all the way to less than 15% as lumping the 2 together. But you can see the survival in years was much better than in the poorly differentiated. Having said that, you must keep in mind that the vast majority of these tumors are the ones above, the well-differentiated tumors / carcinomas of less than 15% proliferation index. So that gives you a wide breadth of understanding and knowledge that even though that's more than the 5% that people split the hairs on, that's never been accurately. We're getting there. We'll probably get close, because what we're doing now is we're doing DNA repair on all of these stains for the Ki-67s that are high and those that are low, and we're matching now how fast does a cell heal itself. And it's very, very interesting that even with higher Ki-67s, the cells heal themselves very, very fast, and they're not amenable to chemotherapy in many stages of the tumor. So these cells are so good that the chemo bounces off of them. We know that. And the reason it bounces off is because they can repair themselves so well. So even a high proliferation stain, and that's why Gene's work is so important, a high proliferation stain doesn't necessarily bode for a more aggressive tumor, although they're working on that with trying to match it with a PET scan. In summary, Ki-67 or the MIB1 is helpful out in pointing out prognostic and therapeutic direction. And the other thing to note is that both the OctreoScan and the PET scan, which is high, when a PET scan is very hot, I'll show you what that means in a moment, it means that the tumor is probably much more active. It's more active than the neighboring tissue from it. And I'll show you a slide on that in a minute. These are the stains for somatostatin that we've been doing now for about 9 years. And this happens to be a very nice stain of, there's the normal liver on the left side, and you can see the tumor, and you can see a very nice, from a distance, you can see that nice dark brown rim. And that defines a membrane of a cell that has a very intense receptor on it. So the membrane of these cells is very replete with somatostatin receptors. And the cytoplasm is also staining. This is very replete with the receptor complex inside the tumor. So the staining shows that there's 2 patterns there, and that has a lot of implication, we think, based on a recent paper by Roybe that shows that when the complex and the peptide, the lock and the key, go in the cell, it has one implication. When it stays on the membrane, it may have another implication. And those are the receptor stains of the tumor. And there, the membrane staining is also positive as well as that. That's probably one that shows the best staining intensity. So that's real somatostatin receptor subtype protein that Gene was showing as a gene. So the gene express the protein that was on the membrane and gives you the opportunity to exploit that with octreotide, the key, because you know it's got the receptors. The stain is against the receptor now. The stain is against the lock now. So you know you can use octreotide with impunity. Not only that, but you can be very much a candidate for radio or peptide radioreceptor therapy using a key that's got a little bomb on the back. And I'll just jump those. Those are examples of other receptor stainings. Now, what are the therapeutic options I showed you on the box? Well, the ones that are, I call cidal or killing, include cutting it out, having surgery, hepatic embolization, whether it's bland or chemo. We're getting away from chemoembolization now because of the damage that the chemotherapy can do to the liver. And then there's the Y90 spheres, which many of you have. And that's going to become important in determining when do you want to ablate the liver lobes with Y90 spheres, you know, based on age, maybe based on degree of liver tumor burden. And then you have the systemic therapy, which is the PRRT, peptide radioreceptor therapy, which is cidal. It kills. And of course, chemotherapy at certain stages will kill. If the cell is growing very, very rapidly and the PET scan is very high, then chemotherapy may be indicated. Static therapy, on the other hand, holds the beast at bay, and that would be something like somatostatin congeners, lanreotide, octreotide. They're anti-proliferative. The anti-angiogenic drugs. Arthur showed a tumor that shrunk remarkably with the Sutent, and maybe that will have implications. Whether it'll grow back or enlarge it again, they're pretty much considered, I think, static therapy at the present time. In terms of surgery and tumor debulking, there are a few studies available, mostly in the United States, coming out of Gene's department and work. They all show benefits with either primary tumor removal, take the beast out whenever you can, get rid of the spigot, and I think the rationale for getting rid of the spigot is my Matisse that I drew for you that shows those darn vessels taking it right to the liver. If you take the beast out, the spigot's gone. So maybe maybe those cells aren't going anywhere anymore, and the ones that are there are the ones that are going to grow. Our recommendations are then, according to the Bible of LSU, you try to remove the primary tumor unless the liver tumor burden is greater than 60%. I think Jane can comment. They're using even higher tumor burdens to take the primary out. And may want to ask questions regarding surgery specifically and indications, because we have the benefit of Gene being here to help us. Hepatic artery embolization using the Y90 spheres. You must try, I think, this is my own experience, to try to determine the percent of liver tumor burden. We use a Doppler ultrasound with grayscale that injects little air beads and can give us a very good volume percent tumor distribution in the liver. And I think we believe right now that 30 to 40% liver tumor burden by Doppler is a safe decision-making tree for embolization to the liver. We use a lot of bland embolization. We haven't put it in a coherent way, and we use a lot of Y90 spheres. But for the most part, we try to, if we're lucky and the patient comes in with 5 or 10 or 15%, we can follow it till it's 30 or 40% before making that decision in that box. We also use pancreastatin. There's soft data, but there's good data from Ohio State, Bloomston, that uses the pancreastatin assay that's a little higher than the ISI when it's 5 times higher. But the number we keep in mind is anywhere from 1,000 at ISI up to 5,000 at Ohio State's pancreastatin. And I think if it gets higher than that, there may be a real risk in terms of considering embolization. Again, that's not a prospective study, but it's one that we kind of keep in mind when we're making the decision for embolization. I still think there is radiation You can get radiation disease to the liver, and it doesn't happen right away with Y90. It's like external radiation. The distance is very short, but it's a high concentration of activity, radioactive activity, and you must be careful for getting liver cirrhosis. And you start to win the battle with the tumors, but then you start to lose the battle because you start to develop damage to the normal liver with this. So the timing at what age and when to use it, I think, becomes very important in your decisions for choosing with your doc that step. The clinical trials I'll just look at and allude to, we heard exquisite work from Arthur on both the ones that are off-label presently and are both available, namely Afinitor or everolimus, and the other is Sutent. But you can see it, and I happen to put it on that tier. I think, for me, I just must tell you, pardon me here, it's toxic. I look at this. When the OctreoScan is positive, you're now in this algorithm of care. You're right here. You're coming down this chute, which includes surgery if possible, and PRRT, peptide radioreceptor therapy. That's the chute that we talk about when you're in the clinic. And you can see everything is still there. You've got tumor receptor negative, that is to say no SST2s, then you think of chemotherapy. But that pathway is what we use, and that's why I put OctreoScan up so high. I can walk in and say, we got good news, and we got good news. We're on our way. Very few times have I had to say, this is OctreoScan negative, and it's real OctreoScan negative. Size of tumors, these are not perfect scans. They don't see anything under 2 centimeters, even in the liver, no matter how good the place is. Gallium-68 may help. It may give us, I think they say 2 to 1, more sensitive than OctreoScan, but it ain't 100 to 1. PRRT, now the OctreoScan you need for PRRT, if the OctreoScan is positive, patient's eligible for somatostatin congeners. Tumor growth with symptoms is another indication. Tumor growth without symptoms is another indication. Stable tumor with symptoms is an indication for octreotide. Peptide radioreceptor therapy can be used when the OctreoScan is positive. And I use somatostatin, a lot of it, when the pancreastatin rises, because it sees liver tumor activity 3 to 4 weeks before the CT scan shows up positive. Months, even. So months, even. Pancreastatin will say the ground is shaking, and you can expect the CT scan to reflect it, and at the event, say 6 months, maybe it'll start showing. Now, this is a case that makes the point about the PET scan and the OctreoScan. This gentleman came in, wasn't necessarily symptomatic at all, actually, but he had tumor by CT scan. On the left side is the OctreoScan, and we did an FDG PET scan. And it looks almost like the left side of the panel. So as the clone was talked about, Arthur alluded to the clone of a cell becoming another hormone-secreting tumor. In this case, these bad cells were hiding underneath the good cells, and you couldn't see them with just the OctreoScan. But the PET scan said, how fast are those tumors growing? And look at how dark it is on the far right. So this patient had a very active set of cells that were active, and a very active OctreoScan set of cells that bound a lot of somatostatin to their receptor. Patient was treated first with chemotherapy for 5 cycles, then sent and got Y90 therapy 2 cycles, 360 millicuries at Basel, Switzerland, and is now 4.5 years out. And he had total weight loss. I mean, he was very sick. He wasn't symptomatic, but he was symptomatic with tumor weight loss. This is the compound we won't see forever in the United States. This was called Onalta, and then it was called Etiotriotide. Novartis called it OctreoTher. But what it is the picture on the right. The picture is that of octreotide. with a replaced amino acid there in the middle, and then attached to a cage which holds the Y90. And the way it works, you all know this is a cartoon killing a tumor with molecular targeting. You put it in the vein. It works its way down through the vein onto the 7-membrane receptor of the tumor cell. Sits there for but a second, may only stay there. The receptor, the complex may not take it into the cell, but here's the beauty of Y90 and lutetium. Doesn't have to get into the cell to do its job, because if in this case it went into the cell, it, as Gene accurately told me a long time ago, that it gives off its targeted point of radiation, not on the cell that it's bound to, but 8 millimeters away from it. And not only that, but, oops, what happened here? Pardon me. Oh, it died on me. It did kill the cell. Hang on a second. There's an explosion. I knew that. Here, there it is. That's it. It goes in all directions. So the primary cell that housed the key fitting into the lock becomes a source of energy for kill next to itself 8 millimeters away. Just a couple more minutes, and I'm going to be done on the sensitivity of the tumor markers. And Arthur was kind enough to give me some space on the markers. I'll repeat what was said. But I believe the blood markers are earlier than the OctreoScan or the PET scan, and they'll give us a message. The OctreoScan and PET scan is earlier than the CT scan and the MR. And the CT scans are the least sensitive, but at this point, with RECIST criteria, we have to consider them the gold standard for stability or minimum tumor increase, or with RECIST criteria, the CT scan has to show a 20% increase in tumor burden. But at this moment, we are using the CT-MR to make decisions for which option to go next to. And I can sing to the moon for labs, and I'll say I'm worried because the pancreastatin is rising. And that does change the way I behave, because people who know me know that I'll increase the octreotide if the pancreastatin rises. The markers most are biologically active in our blood, such as serotonin or substance P. And in many cases, as we learned, you make too much of a good hormone and you may have a syndrome, or you may have a complex of symptoms. And I say when the tumors are clinically active, you don't sit on them even if the CT scan shows no change, because the symptoms and the size of the tumor do not match. You may have a few BBs in there, but if it's an active tumor making serotonin, it can cause many very subtle symptoms that can be debilitating. And these are just for your edification, the tumor and the symptom and the hormone. And as you can see, carcinoids of the gut, mid-gut especially, are high in serotonin. The symptoms I think are important for me are perspiration at nighttime especially. And wheezing can happen in about 20% of the time, and so on and so forth. Whatever hormone wins, you'll have the symptoms, usually. Again, these are the foregut carcinoids we talked about. They have a low content of serotonin, so it's not a useful marker. Chromogranin A, on the other hand, in the sed-rate fashion that Arthur described, could well be a good marker for following foregut carcinoids, especially if they start to grow. My experience is they don't predilect to the liver immediately. They stay in the lung, around the lung, they go to the other side, and they run along lymph nodes. It takes a while to get them down to the liver, whereas the tumors, carcinoids below the diaphragm, predilect to the liver. The foregut ones in the lung do not predilect as immediately to the liver. The midguts we all know much about: high serotonin, high chromogranin A, and also substance P. Co-released, serotonin is co-released with substance P, another very vasoactive substance, which can cause bronchospasm. It's been implicated in the heart disease, of the valvular heart disease. It stands for substance pain, and I call it the hormone of the senses, the survival hormone of the senses, because it's very hard to change the levels normally in our body. And that's because under stress, duress, assault, whatever, you hear better, you see better, you smell better, you feel better on your feet. You're enhanced. All your senses are enhanced with substance P. Too much substance P can give you hyperalgesia, hyperasthenia, and you can have pain, not a phantom pain, you can, but I noticed that pain, nondescript pain is a problem in many of my patients who have high substance P, and it's hard to get low. And there is a drug that's pretty helpful. It's called Lyrica, and it's been successful in 1 or 2 of my people that I have high substance P in. Hindguts they're not bad if they're in the rectum. They're usually benign in the rectum, but if they're in the large bowel, the cecum, or colon, we hope to be able to have a marker like CGA, or as Arthur alluded to, glucagon-like peptide 1. Again, serotonin is high in the midgut, the ileal and jejunum. The foregut carcinoids have very few granules for serotonin, and the hindguts have very, very few. I like the 5-hydroxyindoleacetic acid. It's very helpful, as was alluded to, but normally serotonin has to be high, and it's the serotonin that comes out of the liver that is metabolized by an MAO that breaks it down to 5-HIAA. We all make serotonin from our intestinal tract, and the kidney has the enzyme to break serotonin down, but when you have that extra bump of tumor in the liver, you start to get high production of 5-HIAA. And I usually haven't seen it elevated until there's at least 20% liver tumor burden from the midguts to the liver before it rises. We heard about Chromogranin A, and it's considered a prohormone, and it becomes pancreastatin. It's broken down by a hormone that was mentioned, prohormone convertase 1. It happens, we believe, that this enzyme is very high in liver metastatic tumors. And when it's high in the liver with the tumor there, just like serotonin is broken down to 5-HIAA, we believe Chromogranin A is broken down into pancreastatin, and it reflects liver tumor burden, activity, liver tumor activity. So pancreastatin probably says how active is the tumor in the liver. Chromogranin A may prove to be a good tumor burden marker if everything else is okay. Again, the caveats we've seen many times. It's a matter of knowledge now. Proton pump inhibitors, especially the stronger ones on longer periods of time, we don't have exact numbers, raise the gastrin, shut off the acid, raise the gastrin, and the gastrin turns on little cells in the stomach that can make very high levels of Chromogranin A. We've seen levels over 1,200 from people just being on Nexium or the other powerful one, Acifex. And so you need to be careful, and now they've cut down how long. They used to say you could take these things for 5 years. They're now down into the months is how long you should be taking them normally. But they can, and you always should think if your Chromogranin A is high, you should, and you're on an acid inhibitor, a pump inhibitor, not Zantac or ranitidine, those don't raise gastrin. But the proton pump inhibitors almost always, and especially if you've been on it for a while, you should always think to have your gastrin level measured. If it's high and your chromogranin's high, it's most likely coming from your stomach and not your tumor. Again, hypertension, PPIs, renal insufficiency can all contribute to high chromogranin levels. So you really need to be careful. One slide on neurokinin A. We heard a great deal about it. Jill Ardell from Belfast really has put out some very good, very exciting information as a prognostic marker. It was shown by Arthur and Jean, but it may well be a very important marker that can be changed. It can be changed, and you have to know that. If you said, "Oh my God, my neurokinin A is 80," it's bad. It can be changed. You can perturbate it. You can intervene. You can use sandostatin, and if it drops, That's all good. So neurokinin A is another good marker. One of the questions I saw today, I'm not sure I know the answer. I think we agree that it's coming from the midgut, but somebody said, does neurokinin A, can it reflect activity in the lung? And I sometimes think I've seen it high, but then other times I think almost all my cases are midgut carcinoids. But Arthur, do you have a feel for that? Okay. So for the most part, we believe it's a very good marker for liver, for a prognostic marker for primary ileal midgut tumors. Pancreastatin derives from the breakdown of chromogranin A. It has been around quite a while, actually. The papers go back quite a few years. But there's about 4 or 5, and Arthur has a slide on that, but there are 4 or 5 studies that clearly implicate a change of pancreastatin of greater than about 20%, either with sandostatin itself or lanreotide, I presume, or a 20% drop with embolization, after embolization, maybe with chemotherapy treatment for liver lesions, but a 20% decrease bodes well for stabilization of liver lesions. And with the help of Inner Science Institute and Paris Mamakunian, who's here, and our group of Arthur and Bill and Jean, we were able to establish an exquisite assay which we think is the best in the United States. And it's from Inner Science Institute. And we used that. We calibrated the Inner Science Institute with the Ohio State assay, which I thought was a great assay because I set that up 19 years ago. And of course, it's got to be good with a name like OctreoScan. So anyway, so we had our first patient came in about a month ago, and she was very concerned because her pancreastatin, upper limit's 135, her pancreastatin was 254. And I said, oh, where did you get it done? And she said, Ohio State. So we promptly divided by 5. And you know, because it's 5 times more, it measures chromogranin A. That's why the levels are higher at Ohio State if you get one from Ohio State. And we divided, it was 54, and the one she had 6 months ago was 59. So from Inner Science Institute. So it's I think we did I think the service was given because you can have them. They are interchangeable with that factor of 5. You just have to remember that. But in her case, she had no activity at all in her liver. But that's what that slide shows. And this is one that Jean has compiled over, as you can see, years. But the patient, the pancreastatin level was rising. You can see it rising. And every time it was rising, something was happening in the liver that caused intervention with embolization. The CT scan was a little slow at times with the pancreastatin was rising. And on the floor is 5-HIA and chromogranin A. It didn't budge at all. And this is where we started to get the feeling. And you can see that one bar talks about very active. And the change was from 100 only up on the left side to about 250. And there was intervention there with embolization because it rose and you can see a nice drop. That's how exquisite it is. And if you look at the units of the two, chromogranin A looks like it's measured in pounds. It's called nanograms per mil. Pancreastatin is measured in picograms. That's 10 to the minus 12th grams. So it's much more sensitive than the chromogranin A. But it's a piece of chromogranin A. You got to understand it's on the carboxy end. So in conclusion, serum pancreastatin level is an easy and useful method to predict early liver tumor activity. How often? Probably 3 to 6 months. 3 months you can do it, just a blood draw. CT scans depends on the activity and the judgment. Many of you go to medical oncologists who are instinctive when it comes to how to do CTs, how to monitor. But the boxes were alluded to, and I hope you have questions on those because those are not the easy decisions. It's not linear. The history, the progression in time of what was developed is linear, but the but when to use it, how to use it, combination use, that's what that's what your management plan is all about. And I encourage you very much, rather than to run to the one corner, one group, and I'm not knocking Northwestern. Salins is a magnificent person, but he has nobody around him. He takes his patients straight in for Y90 spheres, and he discharges them back to the doc. And you need somebody who has a big plan that can see you and show you that sheet every time, or talk about that sheet every time and say, okay, this is happening, here's the options, and go from there. So I just appreciate the time. I wish you peace, and thank you very much.